Ah, hello, everybody. Good evening. Let me start first by saying it is my honor to serve as host and moderator for tonight's program. For more than a decade, the A. Philip Randolph Institute has been on the forefront of healthcare. Two words, access and affordability. We believe that equitable and accessible healthcare is a civil rights. And I am not shy about saying that within our community, it is absolutely necessary at every occasion to point that out. Every year since 2009, we have featured health symposiums annually at the National Education Conference. We've explored healthcare topics from dental care to high blood pressure, to childhood obesity, to mental health, including depression and suicide. We've had at least three surgeon generals as our guest speakers and presenters at the conference: Dr. Joyce Lynn Elders, Dr. Richard Carmona, and Dr. Regina Benjamin. And all along the journey, the Kaiser Permanente organization has partnered with us. We are delighted that they are joining us again for this new and exciting webinar, Everything Health. This weekly webinar will explore everything health from the perspective of current trends and with experts in the healthcare field. For the past 18 months, healthcare conversations have been focused on the COVID-19 pandemic. But as we know, our Black and Brown communities were disproportionately impacted by the virus, by the lack of access, and by the lack of healthcare facilities, and still remain high on the list for those who have not been vaccinated. This pandemic has also heightened the apprehension of many of our brothers and sisters, especially when it comes to new or experimental treatments. We only need to mention the Tuskegee experiment for most of us to know exactly what we're talking about. I'm sure many in our audience are shaking their heads in agreement right this moment. So it is fitting that we welcome our first guest. And I'm smiling because this is a dynamic leader, Ruth Williams Brinkley, who is president. I say that three times when there's a sister because I am so proud. She is president of Kaiser Foundation, the health plan of the Mid-Atlantic States Incorporated. And in this role, she oversees all of Kaiser Permanente's care delivery and health plan operations in Washington, D.C. and suburban Maryland, in Baltimore, and in Northern Virginia. Let me say to you, my sister, welcome, and we thank you for joining us for tonight's conversation. I am so excited that you have agreed to share with us a little about the numbers, particularly how this virus has highlighted health disparities. And from your perspective, is there a vast difference in who is receiving the vaccine and who are not? Now, as I look at your face, I see you kind of nodding and smiling just a little bit because we've all heard the mythical stories about why we're not taking this stuff and some of the real deal about folks going into the neighborhoods and communities that had the virus, the injectables. Uh, they go in and they take them and said that nobody wanted to take them. And it's a whole bunch of stuff that's out there. And I'm rambling because I'm anxious to hear you speak. I want something that comes to this table tonight as truth. So, Sister Ruth Williams Brinkley, President, would you please share some of your knowledge with us tonight?
Thank you, Cleola. I am really pleased to be here. It's a privilege. For those, a little bit about us, for those of you who are unfamiliar with us. Kaiser Permanente is a leading national health system with a mission of providing high quality, affordable health services. Across Kaiser Permanente, we have more than 22,000 physicians, almost 40 hospitals, more than 200,000 employees, and nearly 700 medical centers. Now, in the Mid-Atlantic region, we don't own hospitals. However, We have several partner hospitals that work with us to provide care for our members. Today's audience you might be interested to know that currently, also you might be interested to know that currently across our system, our total Kaiser Permanente system, which goes from Hawaii to Oakland, California, to here in the Mid-Atlantic states, 75% of our workforce is union represented. We have 62 local contracts and 41 union locals. 82% of these employees are in what we call our labor management partnership, which is a joint strategy to lead organizational change. It creates an environment of continuous learning and improvement, and it involves our workforce in decision making. The partnership is jointly led by Kaiser Permanente and our two partnership unions. This group represents the largest, longest running, and most comprehensive partnership in the US. So at Kaiser Permanente, we live our values with the goal of improving total health for our members and the communities in which they live, while also creating a great place to work. And I want to add, and this is very important, this is very consistent with the mission, goals, and purposes of the A. Philip Randolph Institute. And I think that speaks very highly to the reason that, some of the reasons that our partnership with the A. Philip Randolph Institute has endured for such a long time. Next slide, please. The COVID-19 pandemic's catastrophic impact was felt across the globe, quite frankly. We are in our region. These are our statistics. So I already spoke about those. So let's go to the next slide, and I'll talk a little bit about the pandemic. It's had a catastrophic effect across the globe. Nearly 600,000 Americans have died from the virus, and across the world, across the globe, 3.8 million people have died. That's a lot of people. More than 175 million confirmed COVID-19 cases globally. It has had a tremendous and disproportionate impact on people of color, quite frankly. Black Americans, just a few statistics, Black Americans are nearly 1.5 times more likely to contract COVID and almost 3 times more likely to die from the virus when compared with white Americans. And then another fact is that Black Americans face a much greater risk for heart disease, diabetes, and other conditions that make COVID much more of a risk. The healthcare system, as we know, from Tuskegee and other examples, the healthcare system has not always properly met the needs of Black Americans. And then finally, from the Tuskegee syphilis study itself, there are historic differences in the care that our people are provided. These things have impacted how Black Americans view healthcare. So here comes along COVID-19, and this virus has demonstrated that Black and brown people face perils that put our health at risk on a daily basis. We have learned a great deal this year. We've learned about how our health system has to do more to better support people of color. And the question is, how do we move forward? Next slide. While we are heartened by the increasing vaccination rates and the decreasing COVID-19 infections, the pandemic has deepened and made very clear health inequities that existed before the pandemic, and quite frankly, will continue long after the pandemic is over or under control. Here you can see that in Washington, D.C., African Americans make up 47% of the population, yet 76% of deaths in the population were those of African Americans. So To say that again, we African Americans make up 47% of the population, but we account for 76% of deaths from COVID-19. Of the states reporting racial and ethnic information related to COVID-19 deaths, Black Americans represent only about 14% of the population, and yet we accounted for 34% of the total COVID-19 deaths. Poor health outcomes in communities of color that stem from structural racism and inequities have been exacerbated by the pandemic. Next slide. So within Kaiser Permanente's connected and integrated health system, we have flexed our resources to deliver vitally needed care during the pandemic. So this is how we have responded. Across our system, we've leveraged our strengths to deliver care over the past year. And I'll share with you some examples of what we've done. First of all, we had a rapid ramp up in telehealth visits. We increased our telehealth visits during the pandemic from 15% to nearly 90% of all physician appointments.
Wow.
Virtual visits for urgent care, primary, and specialty care were a part of this 90%. We expanded home delivery for pharmacy, and that enabled us to increase our capacity. And for pharmacy and medication, we also added curbside pickup, which allowed people to drive up and get their medicines and not have to get out of their cars. And we also did drive-up options for flu shots, for phlebotomy, or getting your blood drawn if you needed a blood test. We made these and many more transitions for the safety of our members and the communities we serve, and also for our staff, quite frankly. Additionally, our decades of experience confronting highly infectious diseases and responding to public health crises prepared us for the COVID-19 pandemic. Although I must say, despite our preparedness, this has been a tough pandemic on all of us. Next slide, please. So what we've done, in addition to the medical and physical health, is we have provided for social health. You would be interested to know that at Kaiser Permanente, we believe that health is more than what we do in our medical centers. And I'm sure that those of you who work in the public health space know that. We know that good health relies on good conditions in our communities. And these are conditions such as having a safe place to live, having access to healthy food, having economic opportunity, and access to healthcare. These are all of the things that happen to people in their day-to-day existence before they ever visit a physician office or a hospital. So along these lines, we've established a very robust commitment in our communities to invest in social health so that we can truly improve total health. We think about healthcare as total health, and that involves a 20 to 20+% of care and what happens to a person's health in a doctor's office or in a hospital, and then that 80% of social health. So some of the things we did during the pandemic was fight hunger. You know, a lot of times we talk about food insecurity, and that's the proper term, but I like to call it hunger because it tells you that people don't have food. They want to eat and they don't have food. So we provided grants to community organizations to support efforts to provide food delivery for those who were experiencing hunger. Racism, structural racism. We committed $8.15 million nationally to various nonprofit and community-based organizations to promote health equity by addressing structural racism and the practices that prevent communities of color from achieving good health and well-being. Another area we worked in was just overall access. We supported safety net healthcare providers who offered low-cost or free healthcare services to ensure access to virtual care for low-income communities. And then finally, the last thing I'll mention is that we provided community grants to organizations and public education campaigns and mass vaccination sites to address COVID-19 vaccine equity. Next slide. The good news then is that the COVID-19 vaccines are here, they're safe, and that they are effective. Currently, 64% of American adults have at least one COVID vaccine, and more than 2.26 billion vaccine doses, that's billions with a B, have been administered globally. That's really great news. In the US, COVID deaths are down 85% since January. So that's good news. That is really good news. At Kaiser Permanente, we've distributed more than 360,000 COVID vaccines in the Mid-Atlantic region and right here in Mid-Atlantic. Unfortunately, however, disparities in the vaccination rate exist between racial and ethnic minority groups in most states. Within the first 2.5 months of vaccinations in the US, the vaccination rate among white people is more than 3 times higher than the rate for Latinx and Black people. About 6 in 10 Black women do not believe the vaccine distribution is taking into account the needs of Black people. So that's something we have to pay attention to and do something about. So we want, next slide, so we want to build vaccine confidence. So in order to do that, we have to increase vaccinations and do something with slowing the spread of this awful disease in Black and Brown communities. So we've launched several initiatives to spread awareness about the COVID-19 vaccine, expand access, and build confidence. And this confidence has to be built in order for people to feel safe taking the vaccine. So we've developed a vaccine equity toolkit, which details approaches to enhance equitable vaccine administration. We've donated $8 million in grants to assist patients served by safety net organizations to get their vaccinations. And we've provided $700,000 in grants for vaccine efforts such as mobile clinics and door-to-door campaign. We will continue to advance our efforts because we know we need to do more and we know that others need to do more. Next slide. We also want to do some things to promote vaccine equity. And so we know that barriers to vaccine administration are real. As implementation of vaccination programs have already revealed disparities in vaccination rates across populations at local, regional, and state levels. So we know we have a problem. So we have a vaccine equity strategy at Kaiser Permanente, and that strategy is rooted in our 75-year history of identifying and addressing health inequities in the medical system, in the public health arena, and society at large. These are real inequities, and we want to do our part to try to address them. We are dedicated to the fair and just treatment, access, opportunity, and advancement of all people in pursuit of their total well-being. We're fulfilling this commitment, and that requires that we redouble our efforts to close gaps in health and address the inequities that I just talked about. We want to also address structural racism and injustices that have marginalized communities and made populations more vulnerable, including those hardest hit by COVID. And you know, it's also made some people fearful. And so we want to decrease the fear and make sure that people know that they can get their vaccine safely. So we have to address these disparities in rates. We have to tailor our response to make sure that we can use data to adjust our messages and really destroy some of the myths around vaccine fear and hesitance. And then we have to reverse inequities in distribution and uptake, where we distribute the vaccine, how, when, and so forth. Slide 10, next slide, please. So we want to expand our access to make sure we are truly expanding access to vaccinations across our regions and across the country. So we're taking some important steps nationally and in the Mid-Atlantic region. First of all, we have joined the White House National Month of Action. We joined this to sprint to vaccinate 70% of adults in the United States against COVID with at least one shot by July 4th. We've launched many other programs and incentives to engage unvaccinated individuals and encourage them to get their vaccines, and also to increase confidence and decrease fear in the safety and effectiveness of the vaccine. We also want to provide easy access for people to receive it. We at Kaiser have a presence in 8 states across the US and the District of Columbia, and we're well positioned to accelerate this final vaccine push by connecting with millions of Americans who are not yet vaccinated. So we're trying to make it easier for people to get their vaccine with walk-in clinics, immunity sweepstakes, and we've also participated in the Maryland GoVax partnership. So we are collaborating with the state of Maryland to expand vaccination efforts in specific areas of the state, including Baltimore City and specific counties in Maryland. So Cleola, our work here is to leverage our experience also with these efforts. And then one thing I want to talk about is one last thing I want to talk about is our good health and great hair program. And that involves partnerships with community barbershops and salons. We'll use this highly successful model that's worked very well for us to build vaccine confidence in some of the most critical populations with low vaccination rates. So, I'm going to pause here and let you know how excited we are about our efforts. This is a serious pandemic, and I know you know that. And we are looking forward to making a positive difference in our communities and improving health. So thank you for giving me a chance to share this with you and our audience today.
Oh my goodness. No, thank you, my sister. Leader with the information that is accurate, with the proof that it works, and with walking the walk as well as talking the talk, and connecting with our community in the way that the cultural differences have kept us apart, but doing it in a way that is real, honest, and truthful. Thank you. Thank you so much, my sister. A piece of what I want to do before we go to the questions is to remind folks that it's been a year and a half that folks have been on lockdown. It's been a year and a half that people have had to figure stuff out in different ways. And in our community, that year and a half seems like 3 to 4 years of figuring out some stuff because we didn't have other stuff. Like Ruth was saying, our communities were not wired to be able to access the information as it was coming along, which is why companies like Kaiser Permanente that went into the community to have dialogue with some of those folks who are the ones that already have relationships and trust with people from the community to encourage them to take the vaccine was so important to get our folks vaccinated so that the numbers, bad though they may be, it could have been a whole lot worse if there had not been the strategy, the intent, and the purpose, and the knowledge of the cultural differences that Kaiser Permanente applied to our community and did a yeoman's job of getting that vaccine out. Our community did not have good transportation in a lot of areas.
Right.
So getting to the vaccination site was here's another problem that's facing us.
Yes.
Or being able to utilize those things that folks talked about so liberally on TV as if everyone had access to it.
Yeah.
When we talked about access and equitability, Kaiser Permanente was ready, had already stepped out. And if you heard nothing else that our sister said tonight, you heard where they went, you heard what the numbers were, you understand exactly the impact that it had. Some of those graphs scared the bejesus out of me, understanding that the disparity was so broad. And it dispelled a lot of the myths that were out there about why some of our folks were not vaccinated. Thank you so much, Ruth, for what you gave us tonight. And what folks like yourself and Chris Blass and Fred Mason and others who've been working this piece for as long as we've had a partnership continue to push and plug and assist in making sure that every community has that civil right that is out there for parity, for equitability, for access, to be able to be considered just as important as the rest of the population. Thank you for that. Now, I know I could go on and on. They tell me, like my granddaughter says, Grandma, you got too many words. So I'm going to try to cut my words down right now and see if there are any chats in or questions in the chat, and see who has questions about anything that was covered tonight. I see that Marietta English is on the line. I see Jeff is on the line. Baltimore is showing out. That's a good thing. And some of our other areas here in DC, people are pulling on to the broadcast. This is our first one. So as the word gets further distributed, we know that the numbers will be there. Are there in, let's see, the Baltimore chapter of APRI distributed information in the Black community that was underserved. Thank you for letting us know that. And Marietta sends one to you, Ruth. She says, thank you for the information. This was great. So just knowing, and I got to brag on her just for a second. Marietta headed the teachers union in Baltimore. Well, I know you know her for so many years, and reaching out to the community that gets the word out. This sister, Marietta English, was absolutely in the thick of all of it. But you made a point, and I'm going to ask you about it. You said early on that when it came to the children, that many of them were impacted greatly by the lack of food, that they were hungry. And all of the proper terms was not one that any one of those was one that you choose to pull up to use. You said straight up hungry. And that's exactly what we saw in all of the communities all over the United States. And you didn't do just what you do inside of your health facilities. You provided food.
Yes.
When people are hungry, they can't think, they can't make decisions, they can't do all of that. And when children are hungry, every grown person that's around them is going to have an issue too. So can you expand on the food piece that you were talking about? Because our communities have food deserts as a rule.
Right.
Big
Well,
supermarkets and all of that stuff are missing in our communities. But let me hush and ask you to please expand on what you all did a little, please.
so Cleola, it wasn't just children, it would included children, but it was adults. And many of us may have seen on the newscasts and so forth, where people who never thought they had food insecurity or hunger
Mhm.
before found themselves in a position they didn't have jobs. Their unemployment had run out or hadn't kicked in. And so they were hungry. And I use that word intentionally because I think, the proper term is food insecurity, of course. That's a clinical term. But I think sometimes a clinical term allows us to distance ourselves from hunger, which is what people are experiencing. And
Mhm.
so we provided food, we gave grants for food. We did everything we could to make sure that our members and the communities that we serve had food. And so that is part of the social, what I'm going to call the ecosystem, or the social network, if you will, that we put around our members and their families,
Mhm.
so that that 80% people don't live in doctor's office, they don't live in hospitals, they
That's
live in
right.
their homes, in their
Mhm.
communities. And so we want, for our members, we try to put this net around them, the social net around them, so that they are not hungry. We provide housing, and housing assistance, and as whatever we can to put that network, and working with partners. We can't provide it all, but we work with community partners to help provide for our members and their families and the communities in which we serve.
Well, that is so vitally important. I know A. Fulton Randolph Institute partnered with a bunch of folks as well to do food banks and distributions
Yes.
across the country, because as you lifted up ideas and progressive and proactive activities, and I use activities in a positive sense, we mimicked some of what you were doing because the response was just so very quick. to lift up and recognize how important you are in the community, not just for the healthcare piece, but because it's all healthcare. I
Yes.
see Marietta has her hands up.
Yes, she has a couple of questions. I can give those to you if you like. One of them is, what other things can we do to serve the community? And the second part is, how can their chapter in Baltimore be a part of the food distribution?
Okay. To whom is that?
That would be to, well, either one, but Sister Ruth, if you could give us some idea for our chapters, because they do the work that President Brown was just talking about. And if there's something that Kaiser might have that would help us to do that, what are some of the things that they can do to serve the community? Because they're doing the few food banks. They actually were working a lot of vaccination sets and some of the other stuff. And the specific question was, how can their chapter be a part of the food distribution that Kaiser's doing?
You know what, there, we have a whole network with our community health organizations. So let me get this information to Cleola. And it's too much information for me to put into the chat right now, but we have food distribution partners, because one of the things that Cleola mentioned, and I want to highlight and lift up, is the distribution, because a lot of times people don't have cars. They don't have a way to get to a food bank. So we have a lot of partners. I will get that information to Cleola and she can get it out so that people can participate.
Thank you so
Thank you.
very much. Appreciate that. I see that Israel Carson has his hands raised. Jan or Israel, do it. One of you do it directly. Can you raise the question? Israel, do you want to speak to your question?
Put it in the chat if you like, and I can and give it to her.
Okay, I see that Jeffrey Johnson put in, how do we protect our babies from this new COVID that is spreading fast?
Oh, that is, wow. That is, we don't have the answer for that, but it is a danger. So let me just say, there is no vaccine. I think we all know that if you're under, I think it's 14, you cannot get a vaccine, but that's being worked on. It's being developed, and I am hopeful, from what I've read and seen, that a vaccine may be available by fall. Until fall, I think that we have to continue to practice masking, washing our hands, and putting masks on our younger children. And everybody, I am just, it makes me just, what's the word I'm looking for? It makes me very uneasy sometimes when I go out in the community. Recently, in the last couple of weeks, people are unmasked.
Yep.
And if you're out in the air and walking, that's different from being in an enclosed environment. So I would say continue to do the social distancing, continue to mask. And if you've got little ones in your house, just be very careful, because you're not masking for yourself if you're vaccinated. You're masking for those little ones and anybody else who might be vulnerable. So we just have to practice the things that we know have worked over this last 18 months, and just be hopeful that we will have a vaccine by the fall. I don't know what the specific date is, and I don't think one's been given, but there's hope and plans, anticipation that there will be one by the fall for little kids. Because I've got little grandchildren as well. Cleola mentioned her grandchildren. I've got little grandchildren that aren't vaccinated. So we make them mask, and we mask when we go out to make sure that they are protected.
Yeah, absolutely. Absolutely. And it's pretty scary, because the attitude that was taken almost immediately after numbers started to drop on the infection, and the death toll went down pretty quickly as well. Folks just went straight up crazy and started running outside like there was never a virus.
Yeah.
But I watched our community, they're a little bit more cautious than some of the other folks, because it's hard for us to believe that hokey doke when it comes rolling out. We do understand that some of it is about the dollar. We get that part. And a lot of our folks have to go out to help make that dollar in the frontline jobs that they hold. And
Right.
that too is very scary with this new virus coming up. Okay, I see, Jan, you have a couple of more that's in the hopper that you can see that we can't.
See, yeah, those are the two that have been answered, but there's another one. There's one from Israel Kassan, who wants to know, what are we doing to address the addicted population? Would you have any insight into that, Ruth?
While the pandemic was it was at its height, we were all fighting that, and most of our efforts went to that. And I'm glad someone brought up the addiction population, because addiction did not go away. In fact, some studies are starting to show that it significantly
Right.
increased during the pandemic.
Mhm.
And if people aren't working, they're inside, I'm not an addiction specialist, and I don't want to even suggest that I'm talking about behaviors that drive addiction, but we do know that the numbers went up. So we need to try to get people back on some type of program and back in to see their addiction counselor, their addiction specialist. Addiction I know I'm not telling you all anything you don't know. Addiction is a very hard disease to fight.
Yeah.
And so persons who have addictions need a lot of support. They need a lot of structure to stay on that pathway and to stay away from the things that drove them to addiction to begin with. So we're starting to see people coming in, because quite frankly, a lot of people didn't come in during the pandemic. They didn't come in for anything. They were afraid, and with good reason. So now we're seeing that we're seeing those numbers. I don't know if they've gone up, but we're seeing more people seeking treatment. So that's a good thing. So we are trying to doing our best again to make sure that we can start to address that now that the COVID numbers have gone down significantly.
As always, you guys are right there and on point. It's pretty scary when you just had a chance to take a deep breath and say, whew, at least there's a beginning to a light showing somewhere. And then an announcement comes that speaks to yet another virus being
Yeah.
introduced all over everywhere. And they can't seem to give us pinpointed directions for where the virus is hitting. And I guess that's to arrest some of the panic that is anticipated about the new virus. Is
Well,
there?
it's a variant. I'm sorry, Cleola.
No, please go ahead.
It's a variant of the COVID-19 virus, and it's called the Delta variant.
Yeah.
There's been the South African variant, and then there's been a Brazilian variant, and now there's this Delta variant. And it is the literature has said that it's very transmissible and highly virulent, which means it makes people really sick. There was a program on NPR. I think I want to say it was Monday night, and it wasn't our area. It was in Missouri, but it sort of gives you a snapshot of how things are working there. One of the gentlemen from a system, I think it's Cox Health System, said his COVID numbers, and it's the variant, are if I'm remembering correctly, I know it's COVID, I believe it's the variant, that the numbers are starting to look like the numbers he had last fall, which is a scary thought. And more specifically to this area, what I've been reading is that the Delta variant is very prevalent in the Northeast and the Mid-Atlantic areas, which is us. So that, and if you're vaccinated, it protects you from the variants. That's the belief. That's what the science is telling us today, that you're protected. But viruses mutate,
Yes.
and they change form to survive. And so we just need to be careful. The other alarming fact, and I want to I'm pretty certain I'm correct. It's younger people who are now, I think the 18 to 30-year-olds, I believe, but don't hold me to that number, but it's in that age cohort that are the sickest.
Yes.
And getting the virus. That group is eligible for vaccines, and not sure why they're not being vaccinated.
It's interesting when we speak with some of our young folks, and we have a large following of youth inside of APRI, and they will watch to see who's going to drop first. I'm just being plain and straight because there's so much stuff out there, bad information.
Mhm.
Urban tales are just everywhere about what happens when you take it and you're not 21. It's crazy the kinds of myths that we have to face and discuss with our young people. I hope that as there is more clarity about what these variants do or where they are, that we'll be able to get some of that from you to share with our youth population. Because a
Mhm.
lot of our young folks are saying, and some of our sports figures are also saying, well, I didn't get it yet, and I didn't take the virus because I'm healthy, this, that, and the other. We've got to be on them from the beginning. And because they were excluded at the top of this epidemic,
Mhm.
now the vigilance has to be shown there as well.
Right.
I see some, go ahead, I'm sorry.
No, you are absolutely right. And I don't know what I heard on NPR, and I suspect it's similar in other places, is that some people are coming in saying, I can't believe I was so stupid and not taking the virus. These are critically ill
Yep,
people. And
yep.
then others are still, there's still that thought out there that it's a hoax, that it's not real, and people are going to take their chances. Just what you said, they believe they're healthy, but you never know. This virus is very tricky in the sense that sometimes people who have a lot of what we call comorbid conditions, high
Mhm.
blood pressure, diabetes, they pull through, and sometimes people who are very healthy don't pull through. So it's not clear who's going to pull through, and so the best protection we can get is to get the vaccine. It's the best protection we have today.
Well, you answered a question that popped up from Chris that says, to those who have not been vaccinated but on the fence, what can you say to them and their families? Your answer was very clear just now and succinct about what our responsibility is and what it is that we need to be doing right now to make sure that this stuff gets stopped real quick and that people still continue to practice the safety measures that we've been talking about for a year and a half and hope that it sticks for sure. You
Yeah,
have,
I know there's a distrust that's out there. Um, I would trust, I got the vaccine. Let me just be really clear. I got my 2 doses, and
Mhm.
I was thankful to get them. And I know I'll just tell you the way I'm thinking about it, just to be real about it, Cleola, as you had mentioned. I would rather take the chance, if there's a chance of getting the vaccine, than taking a chance of getting COVID. I would, because
I understand.
it's been devastating to people. And you think about, many of these people go in the hospital, they are separated from their loved ones. It's great expense to their loved ones for the hospital expense, the loss of income. you know I just think people need to think about the consequences that of getting COVID, and hopefully they will make the right decision. And even those who sometimes get it and survive, they often have lifelong symptoms. So I come down on the side of it's safer to take the vaccine.
Absolutely. Absolutely. There has been a wealth of information shared this evening on the real side about where we are, what we're doing, and what we must continue to do. The stats that you gave from your slides made me
Yeah.
sit up straight when our numbers are so disproportionately higher than our
Yes.
population input for the entire society. That's the real stuff.
Right.
And you gave the national as well as that regional number. And it is just as bad nationally as it is regionally. And if we don't stay the course, especially having friends like Kaiser Permanente that continues to give us the information to share to our community, then it's shame on us. We've got to do this. We
Yeah.
have got to do this. So I thank you so very much for all that you've done tonight. There are pieces popping up in here, and I see that Jamie Sorensen also asked a question. We're just about, and I don't want you to get mad, Ruth, because we're going to ask you to come back again. But we are at our cutoff time. But can I just raise that one that Jamie Sorensen lifted up? She said, can you explain how the new Delta variant symptoms differ from that of the initial COVID? She says, I heard that they are more like a cold. Is that true, or is that one of those urban legends?
I don't know the answer to that.
Okay.
I really don't, and I would want to have a physician answer that.
Mhm.
But it seems, what I've not read, that what I've read is that it's the same as the regular
Mhm.
COVID. The symptoms are the
Mhm.
same,
Mhm.
and you get just as sick. But I don't want to give misinformation, so I don't know the answer. I really don't.
Yeah, 2 nights ago, I saw with, oh my God, it was on CNN, and I forget who was doing the talking. I'm so used to Sanjay Gupta, but the person that was giving the information said exactly what you just said, that although there are variants, it mimics the original, and folks should not be not serious about taking these variants as serious
Exactly.
as they did the original virus.
And yes, and what I've read is that it is deadly.
Yes,
It's
it
that
kills you a lot
Yeah,
quicker.
yeah,
Yeah.
that's what I've read, and
Mhm,
that's sort of normal for
mhm,
viruses as they mutate, they get stronger,
mhm,
and so I don't know all of the scientific facts behind it, but
mhm.
I wouldn't take a chance on getting it. That much I would say.
Absolutely, absolutely. Well, folks, it must be good information that you're getting, because the numbers are continuing to build as opposed to dropping off as most of the webinars do. And I'm getting the hit from Dave. Dave, how are we with time?
Yep, we are good. I just want everybody to hold on. I got a quick announcement, but yeah, but you can continue on, Miss Brown.
Okay, can we take at least one more of these questions? Because this one that popped up came from Janelle Edmonds, who is a dynamo in the Baltimore area through our APRI chapter. You should have seen her out there with everything that was going on to encourage folks to do the right thing. She's saying that in the community that some nurses are not taking the vaccine.
Well, that's probably true. Some of you may have read, not it's I wouldn't call out nurses specifically. What I would say is that we do have some healthcare workers
Refuse.
healthcare providers
Okay.
who are not willing to take the vaccine. And some of you may have read a case in Texas. This is the most prominent case that I've read about in Houston. It's Houston Methodist, where there were about 131 nurses. I think they were all nurses who refused to take the vaccine. They were terminated or resigned, and they filed a lawsuit. And the hospital, they won, and the hospital appealed. No, wait a minute. They filed a lawsuit. The judge ruled against them, so that now they're getting ready to appeal. I would say that I would encourage every healthcare professional, persons who are healthcare worker,
Mhm,
to get the vaccine,
mhm,
if you can see your way to doing so, because you're with people all the time, and you cannot determine who has the
that's-
virus just by whether they're coughing or have symptoms. As those of you who work in healthcare know, sometimes a disease is most transmissible before the symptoms appear. And so, especially respiratory illnesses and germs and viruses that are transmitted that way.
mhm.
So I would so that is correct. And I would ask our labor leaders to encourage your members to get the vaccine and to protect themselves and their families. I think you have a great role in this, and you have a great voice in this. They will listen to you. So you have to encourage them.
Well, I thank you for that because inside of the labor movement, there is so much that is being pushed towards our membership to encourage them to do so because we want them to stay healthy and
Yes,
because they are frontline workers and they are most vulnerable because they have the interaction between those that we already know are sick.
that's right.
And to be a spreader is just not acceptable at all. So we will continue to do that for sure. I know that we could talk for another hour because you're quick. You are quick, you are clear, you are concise, and I just love having you on for sure.
Thank you.
But what we will do now is listen to what Dave gave us, and he says it in a very nice voice, but he is watching that clock as my phone pops up and tells me, and we've worked you hard. So we wanted to say thank you to you tonight. And
Thank
we are serious about pulling you back again, because as words spread about the depth of your input, I think that there will be people that will come on just specifically to hear you dispel a lot of the myths that are out there. Dave has an announcement, and yep, and I'm looking, and the stuff is still coming up. So we will save some of them for you the next time. Thank
thank
you,
you.
thank you, thank you, thank you. And
All
thank
right.
Pastor Permanente.
Yep,
Totally.
Cleola, I just want to say real quick, just join us next week. Next week we'll have Dr. Tony Lewis on next week, next Wednesday, same time. But I will turn it back over to you, Cleola, so you can close us out. But that was my only announcement.
Okay, well, thank you very much, Dave. And last words, my sister, from you.
Cleola, it's been a privilege to be here and to talk to your membership and people from the A. Philip Randolph Institute. You all are doing a great job, and I know that you all are fighting. We're all fighting this virus, and really, quite frankly, more broadly than this, we are fighting, continuing the fight for racial justice and to stop inequity. So the virus is here and now, but we know that we have a lot more work to do. So thank you all for the work that you do.
We thank you so very much, and we thank the overall health care that is provided by Kaiser Permanente, and we treasure that partnership that we have. We're not going anywhere. We're not going to let you all go anywhere. Because
Thank
as
you.
you say, the
Thank you.
job is still there to be done. It comes up differently all the time, but it's still something that requires people who have that innate ability to
Yes,
communicate. And that's what you all have to make everything real, not scary, but real, so that people
thank you.
participate. And to all of you who were on tonight, we thank you sincerely for joining us. And I'm real impressed with what I'm seeing on my sideline phone, that the numbers are growing as we are talking, but we want to grow even more and more with each one of the broadcasts. So thank you all for being a part of it. And thank you for your service in this fight against COVID with all that you do as leaders within the community. Thank you and have a blessed evening, everybody. Thank you, Steve. Thank you, Ruth. Thank you.
Thank you. Thank you. My pleasure.
Clap along if you know what happiness